Good evening, everyone, and welcome to the Thrombosis Canada Highlights from the International Society of Thrombosis and Hemostasis 2022 Congress, which was held in London, England. This is a Canadian perspective on the meeting. Next slide. I'm Dr. Deborah Siegal. I'm a hematologist in Ottawa, and I'm very pleased to be joined tonight by esteemed colleagues, Dr. Jameel Abdulrehman, who's a hematologist in Toronto, Dr. Schulman, a hematologist at McMaster University in Hamilton, and Dr. Roona, Sinha, a pediatric hematologist-oncologist in Saskatoon. Next slide. This program has received support from Pfizer Alliance in the form of an unrestricted educational grant. And so we have to disclose potential conflicts of interest, which is that the speakers are eligible for an honorarium from Thrombosis Canada and that Pfizer benefits from the sale of a product that may be discussed in this program. Next slide. With regards to mitigating potential bias, the content of this program was developed by the faculty and peer-reviewed by Thrombosis Canada. Recommendations involving clinical medicine are based on evidence that is accepted within the profession, and all scientific research referred to, reported, or used in the program in support or justification of patient care recommendations conforms to the generally accepted standards. This program is accredited by the Royal College for 1.5 hours of activity. So the overall learning objectives of our session tonight are that at the end of this presentation, the participants will be able to discuss highlights of key thrombosis-related presentations from the ISTH 2022 Congress, and discuss highlights of key hemostasis-related presentations from the ISTH 2022 Congress. We have a packed agenda for you tonight, and we'll endeavor to keep your attention and interest you in topics related to thrombosis and hemostasis, followed by some question and answer period, followed by a wrap-up. Next. So I'm going to lead us off tonight. I'm, again, a hematologist in Ottawa. I'm an associate professor in the Department of Medicine, an associate scientist at the Ottawa Hospital Research Institute. I have interests in anticoagulant-related bleeding and other things, but the focus of my presentation tonight is going to be from two abstracts that related to anticoagulant-related bleeding. Next slide. Here are my faculty disclosures. So at the end of my presentation, the participants will be able to review and discuss the risk of clinically relevant non-major bleeding in patients receiving extended anticoagulation for unprovoked VTE, a very interesting presentation, and also review and discuss risk scores for predicting bleeding in patients with cancer-associated thrombosis, also an interesting topic that's very important. So the first presentation was by Faizan Khan, work done in collaboration with others and conducted in Ottawa. This is long-term risk of clinically relevant non-major bleeding during extended oral anticoagulation for unprovoked VTE, something that we can all relate to in our management of patients with thrombosis. Next slide. So of course, patients with unprovoked VTE are managed with anticoagulation for at least 3 to 6 months of treatment. And after that time, patients are considered for ongoing anticoagulation depending on the risk of recurrent VTE and associated mortality if anticoagulation is stopped, and you can see that on the left-hand side of the screen, or the risk of recurrent VTE or major bleeding and related mortality if anticoagulation is continued. Next. So in a prior study, Faizan Khan and colleagues evaluated the risk of recurrent VTE after discontinuing anticoagulation, and they showed something that we're familiar with. This was an important paper published in BMJ. The risk of recurrent VTE was 10% in the first year, 6% in the second year, and 4% in years 3 to 5, 3% in years 6 to 10. So at the end, the cumulative 5-year risk of recurrent VTE was 25%, and the 10-year risk was 36%. Importantly, the case fatality rate of recurrent VTE was 4% in this study. This was another systematic review and meta-analysis. Next. They also conducted a systematic review and meta-analysis of major bleeding for individuals with VTE who are on anticoagulants. And you can see that the risk of VTE, the major bleeding with VKA and DOX are shown in the box on the right-hand side. 1.7% per year for VKA, and 1.1% per year for DOACs, with case fatality rates actually that were 8% and almost 10% with DOACs. And you'll notice that this case fatality rate for major bleeding is actually higher than what they found for the risk of recurrent VTE. So interesting findings for sure, and helps us decide what the risks of individual patients have when considering ongoing treatment after their event. Next slide. But there is an important knowledge gap regarding the risk of clinically relevant non-major bleeding in anticoagulated patients. We know that major bleeding is not the only type of clinically relevant bleeding. So clinically relevant non-major bleeding is an important safety outcome in clinical trials of venous thromboembolism, as it incurs time-consuming management, affects patients' quality of life, and carries important healthcare costs. Next. So the study objective was to determine the incidence of clinically relevant non-major bleeding during extended anticoagulation of up to 5 years among patients with a first unprovoked VTE. Next slide. So they conducted a systematic review and meta-analysis of a number of data sources. They included randomized controlled trials or prospective cohort studies that included patients with a first unprovoked VTE who had completed at least 3 months of initial anticoagulant treatment. And the studies had to include a treatment group that received a vitamin K antagonist or DOAC for a minimum of 6 additional months. Of course, the studies had to have reported clinically relevant non-major bleeding events during extended anticoagulation. Next. So again, the primary outcome is clinically relevant non-major bleeding. It's important to recognize the definition. Here it's any sign or symptom of bleeding that doesn't fit the criteria for major bleeding, but does require medical intervention by a healthcare professional or require hospitalization or an increased level of care or prompt a face-to-face evaluation. And of course, face-to-face was in the times before virtual care and COVID. Next. And we're all quite familiar with major bleeding, which is quite different. Overt bleeding associated with a significant hemoglobin drop of 20 grams per liter or more leads to transfusion of 2 units of blood, occurs in a critical site, or is fatal. So they're quite different, but you can see that clinically relevant non-major bleeding represents clinically significant bleeding events for patients. Next slide. So they calculated the incidence rate of clinically relevant non-major bleeding, which was the number of the first CR and MB events per person time at risk, and this was expressed as the number of events per 100 patient years. Next. They identified over 5,000 records and screened 4,100 titles and abstracts after removing duplicates. 75 full text articles were assessed for eligibility, and 15 studies were included in the final meta-analysis. Next slide. This slide shows the different studies that were included in the systematic review, a total of over 15,000 patients with the first unprovoked VTE. Of the studies, 8 were randomized control trials and 7 were prospective cohort studies. So quite a lot of patients were receiving vitamin K antagonists, almost 8,500, and almost 7,000 patients receiving DOACs. The studies were judged to have a low risk of bias, and 8 of them used the official ISTH definition of clinically relevant non-major bleeding. Next slide. So what did they find? Well, they found that they separated the results according to the type of anticoagulant that was used. So for patients receiving VKAs, the incidence rate of clinically relevant non-major bleeding was 6.5 per 100 person years. And for patients receiving DOAC, the incidence rate was 5 per 100 patient years. So that, although they calculated the 5-year cumulative incidence of clinically relevant non-major bleeding for VKA treated patients, that was 22%. There was insufficient data to calculate the 5-year incidence for patients on DOACs, but 22% at 5 years for VKA treated patients. Next slide. So what are the conclusions and implications of this work? Well, we all see patients in clinic, patients with a first episode of unprovoked VTE. They complete their primary treatment of 3 to 6 months of anticoagulation, and then there's a decision about whether or not to stop or continue. And of course, this is dependent upon both the estimated risks of recurrent VTE and the estimated risks of bleeding. Bleeding includes both clinically relevant non-major bleeding and major bleeding. So now we have something else to consider. Next. So based on the results of this study, the annual risk of clinically relevant non-major bleeding in anticoagulated patients with an unprovoked VTE who remain on treatment for extended duration is not trivial. Again, we saw incidence rates of 6 per 100 patient years and a cumulative incidence of 22% at 5 years. This information could be used to balance the benefits and harms of extended therapy for patients who have unprovoked VTE. Next slide. So we're going to switch gears a little bit, but staying within the theme of anticoagulant-related bleeding. This is an oral presentation by Dr. Kristen Sanfilippo from Washington University in St. Louis. It's called Predicting Risk of Anticoagulant-Related Bleeding in Cancer. Available risk scores modestly predict hemorrhage in patients with cancer-associated thrombosis. It's not unfamiliar to this audience that the bleeding is a major complication of anticoagulant therapy, and cancer patients are particularly high risk of bleeding complications. You can see on this slide a summary of the major bleeding rates for patients receiving anticoagulation for cancer-associated venous thromboembolism. Shown here, the weighted average is 3.9% within 6 months. Next slide. So that's much higher than patients without cancer. This slide summarizes the results of a study showing the types of outcomes that are experienced by patients who have either major bleeding in the middle column or clinically relevant non-major bleeding in the right-hand column. You can see that for patients with major bleeding, a majority of patients, 2/3 are hospitalized, are admitted to the intensive care unit. Many require transfusion support. Here, an important outcome is that interruption of cancer treatment. This is a very important consideration for cancer patients. And then, of course, about a fifth of patients, or 20%, required a procedure. You can see on the right-hand side, many patients with clinically relevant non-major bleeding. As we just talked about, this is a clinically important outcome. Many patients are hospitalized, receive transfusions, and still a proportion of these patients also have interruptions in their cancer treatments or require a procedure. Next slide. But case fatality rates for major bleeding is also an important consideration here. And you can see high rates of death associated with anticoagulant-related bleeding. We saw in the previous study case fatality rates of around 8 or 9%. We're seeing a similar thing here. This is from a systematic review and meta-analysis. You can see that although they're not statistically different, there seems to be a higher case fatality rate in cohort studies of cancer patients compared to randomized controlled trials. And that may just be because patients in randomized trials were selected to be low risk for bleeding. Next slide. So there has been efforts to develop risk prediction models that can help us determine which patients may be at higher risk of bleeding complications. And this slide summarizes some of the risk prediction scores that have been developed. And you'll notice that the majority of these have been developed for patients receiving anticoagulation for atrial fibrillation. That's in the top of the slide. One for cancer-associated thrombosis and one for VTE patients. A number of patients here were included in these trials and receiving different anticoagulants. Again, VTE bleed here studied the most patients with DOAC receiving DOACs. And importantly, at the bottom row of the table here, you can see the C statistic. And this C statistic reflects the discrimination of the model. So the ability that the model has to predict or discriminate between individuals who experience the outcome of interest and individuals who do not. And I can say that a C statistic of around 0.5 is essentially that the model is not much better than chance. And values over 0.7 indicate a good model, and over 0.8 indicate a strong model, et cetera. A value of 1 would mean that the model perfectly predicts which members of the cohort would experience a certain outcome and which ones would not. So you can see here at the bottom, in general, the models here have moderate to good discriminative abilities based on C statistics around 0.6 to 0.7. Next slide. So just keep those numbers in mind. So the goal or aim of this study was to evaluate the performance of these existing bleeding risk models in a cohort of patients who have cancer-associated thrombosis and receiving anticoagulant therapy. They used administrative data and defined clinically significant bleeding using ICD codes. They conducted a competing risk analysis within 6 months of starting anticoagulation, so months 1 to 6 and then months 7 to 12. The hazard was calculated per 1 standard deviation increase in points. So they looked for an increase in in risk according to increase in points based on the risk prediction tools. They were censored after 30 days of the last anticoagulant prescription. And of course, they evaluated the C statistic, again, this discriminative index for model performance. So how well would the model predict who had a bleed and who did not? They conducted their study using the veterans database. You can see here, 500,000 patients diagnosed with cancer between 2012 and 2022. Among those, around 23,000 were newly diagnosed with cancer. In the end, they included a final cohort of 11,731 patients. Next slide. This slide shows the distribution of cancer types, and you can see, I think here, that there was variable cancer types, lung being the most common, that's in darker blue, followed by gastrointestinal, prostate, genitourinary, lymphoma, etc. But what you can see here is that it really did capture a wide variety of cancer types. This slide shows the type of initial anticoagulant that was given. You can see that the majority of patients initially received enoxaparin, followed by warfarin, and then DOACs. Next slide. And this slide is interesting. It shows the trends in anticoagulant treatment for these patients over time. So between 2013 and 2020, you could see in light blue, there was a decreasing use of warfarin, in red, decreasing use of low molecular weight heparin over time, and an increasing use of direct oral anticoagulants, which is probably unsurprising to us. Next slide. This slide shows the locations of bleeding that these patients experienced. There were 932 bleeding events in this cohort. The majority of bleeds arose from the gastrointestinal tract, followed by the genitourinary tract, and then the lungs. Intracranial hemorrhage here was in the middle, of course, the most feared complication of anticoagulant therapy. Next slide. So this slide I don't want to go through in too much detail, just to reflect that there were, these patients were separated according to whether they had a bleed within 6 months or no bleed within 6 months. And you can see those in the middle two columns. And on the left-hand side, you can see a number of baseline characteristics, including age, relevant comorbidities, some baseline laboratory data, previous history of bleeding, and concurrent antiplatelet therapy or NSAID therapy. All of the things that we would think about would potentially increase the risk or modify the risk of bleeding, including cancer type. And they've identified here genitourinary and gastrointestinal tract and metastatic disease as well. And you can see on the right-hand side for the univariate p-values that there were differences in the baseline characteristics between the groups, some of which may not have been clinically significant, but also some not surprising. Next slide. This table summarizes, and I'll ask you to focus your attention on the left-hand side of the table. You can see the score, the type of risk prediction model that was used on the left-hand side, so atria, cat bleed, has bled, hemorrhages, etc. This table reflects the association between scores and anticoagulant-related bleeding within months to 6. So among the risk prediction models shown here, the ones that had the highest magnitude of risk per 1 standard deviation increase in score were atria and hemorrhages. These were the ones here which had the highest C statistic at 0.59. On the right-hand side of the screen is a sensitivity analysis where they just looked at the ICD codes in the first 2 positions, which reflects a similar type of information. And I just want to recall the fact that a C statistic of 0.59 means that the model is modest at being able to predict who's going to have an event and who is not. Remember, a value below 0.4 indicates a poor model, and 0.7 is a good model, so we're sort of in the moderate range, 0.59, not much better than chance. Next slide. Similarly, with regards to bleeding between months 7 to 12, we find that atria and hemorrhages here, hazard ratios around 1.36, 1.34, and the C statistics in the 0.59 to 0.6 range. So again, modest predictive ability. Next slide. So what can we conclude for this study? I mean, I think that this study confirms what we already knew, was that cancer patients have a high risk of bleeding. We have a number of risk prediction models that have been developed for other populations of patients that perform poorly to modestly with regards to predicting anticoagulant-related bleeding in patients with cancer-associated thrombosis. Clearly, this is an area of need. We obviously would want to be able to predict who is at highest risk, and maybe that would change our treatment with respect to the type of anticoagulant or the duration of anticoagulation. Although atria and hemorrhages had the highest discrimination ability and maintained performance, this is actually, modest at best. And that it really is important to develop these types of models to accurately quantify bleeding risk in cancer patients, to minimize prolonged exposure to anticoagulation in these high-risk patients and potentially improve outcomes. So I'll now pass the microphone over to Dr. Jameel Abdulrehman for the next presentation.
Great, thank you. So I'm a hematologist and clinician investigator with specialization in thrombosis and hemostasis at Toronto General Hospital within the University Health Network, and an assistant professor at the University of Toronto. My research interests are in clinical studies and the use of anticoagulation in special populations. Next slide, thank you. So here are my disclosures. So the learning objectives for this session are first to review and discuss low molecular heparin in pregnant and postpartum women with previous VTE. Specifically, we will look at the study intermediate dose versus low dose low molecular heparin in pregnant and postpartum women with a history of venous thromboembolism, the HILO study. This was presented by Dr. Saskia Middledorf at ISTH as a late-breaking abstract. And second, we will look at review and discuss DOAC pharmacokinetics after bariatric surgery. We will look at the study pharmacokinetics of DOACs after bariatric surgery, a retrospective cohort study. This was presented by Dr. Barbara Gunka as an oral abstract. I'd like to thank both Dr. Middlesdorf and Gunka for sharing their presentation slides with us today so that we can go through them in detail. Okay, next slide. Let's start with the HILO study. Next slide. So pregnancy and the postpartum state are well established as risk factors for VTE. The risk is estimated at 1.2 per 1,000 deliveries. The risk is even higher in women with a history of VTE, estimated to be as high as 2 to 10% of those without thromboprophylaxis. So this is a major concern, as VTE in pregnancy is a leading cause of maternal morbidity and mortality. Next slide. So because it's high risk of VTE, the guidelines suggest thromboprophylaxis with a low molecular heparin. So in women with a history of VTE, not currently on anticoagulation, if they had an unprovoked or a VTE associated with a temporary hormonal risk factor, so for example, combined oral contraceptive, the guidelines suggest antepartum thromboprophylaxis through the entire pregnancy and also postpartum 6 weeks. Next slide. The challenge with low molecular heparin in pregnancy is the dosing. So in pregnancy, there's an increase in weight, increase in plasma volume, and changes in metabolism, such as increased renal clearance. All these things affect the pharmacokinetics of low molecular heparin. So it's unclear if the low dose, the standard dose, is sufficient. Should they receive a higher dose? Should the dose be adjusted as their weight changes in pregnancy? It's unclear. The drawback to these higher doses is potential for higher risk of bleeding, higher cost, and it may limit access to neuraxial anesthesia. Next slide. So to answer this dosing question, the investigators designed the HILO study. This was an investigator-initiated international open-label RCT. They included pregnant women with a history of VTE that was either unprovoked or related to a hormonal risk factor, and that were at maximum 14 weeks gestational age. They're randomized to either intermediate or low-dose low molecular heparin. We'll take a closer look at what that means on the next slide. The primary efficacy outcome was symptomatic VTE up to 6 weeks postpartum, including DVT, PE, and unusual site thrombosis. The secondary outcome was the 3 components of the primary outcome: objectively confirmed superficial vein thrombosis, SVT, and then composite of VTE or SVT. The primary safety outcome was major bleeding as defined by ISTH criteria. Secondary outcome was the composite of clinically relevant non-major bleeding and minor bleeding. The outcomes were adjudicated centrally by a committee blinded to study drug allocation. Next slide. So with the intermediate dose low molecular heparin, this was about a half therapeutic dose. It was dosed once daily, and the dose was adjusted as the weight changed in pregnancy. Whereas with the low dose, this was fixed from time of randomization, and this was the standard prophylaxis dose. Next slide. So with the stats, So the calculation for the sample size was event-driven. They were targeting 29 primary outcomes. They made the assumption of a 65% relative risk reduction with intermediate dose compared to low dose low-molecular heparin, power of 80%, and alpha of 0.05. Expecting an incidence of VT of 4 to 5% in the low dose group, they expected the sample size of 859 to 1,074. There were 3 study populations. The first was the intention to treat. This was all randomized women. The second was the safety population. This was all women who received at least 1 dose of the study drug. And then the per protocol. So per protocol was women without major protocol deviations, self-reported adherence of 80% or more, and who received at least 1 dose of the allocated study drug. For the analysis, the efficacy outcomes were adjudicated from randomization to 6 weeks postpartum in the intended to treat population, and the safety outcomes were adjudicated in the safety population during the on-treatment period. So 1,110 women were randomized into the study. There was a low rate of loss to follow-up and withdrawal of informed consent. In the end, both groups had 555 women in their intention to treat population. Next slide. The mean age was 32 with a median BMI of 25. We can see the baseline characteristics are well balanced here between the 2 groups. Next slide. So here we have the results. So with our primary outcome of VTE, there was no difference between the intermediate dose and the low dose. Looking at the composite outcome of VTE or SVT, there was a decrease with the intermediate dose low molecular heparin with a relative risk of 0.45, 95% confidence interval, 0.24 to 0.85. There was no difference in major bleeding or composite major or clinically relevant non-major bleeding. Next slide. So if we look at the components of VTE, we can see with the intermediate dose, there was a decrease in PE with a relative risk of 0.11 and a decrease in SVT with a relative risk of 0.23. Next slide. Looking at the timing of the bleeding, the majority of major bleeding occurred in the early postpartum stage, and a few episodes occurred in the late postpartum. Next slide. Here we have the survival curves. On the left, we have VTE. On the right, major bleeding. The blue line is the low dose. The red line is the intermediate dose. Next slide. And then finally, the investigators looked at VT outcomes by pregnancy stage. So if we look only at the antepartum stage, we can see no difference in VTE or composite VTE SVT. If we look at the postpartum stage, we can see there was a decrease, a numerical decrease in pulmonary embolism, composite VTE or SVT with the intermediate dose compared to the low dose. So the strength of this study was this was the first large thromboprophylaxis RCT in pregnant women with a history of VTE. It had careful documentation of efficacy and adverse events. There was a central adjudication committee, which was blinded for treatment allocation. There was a low rate of loss to follow-up, and the study was international, multi-center, and pragmatic, so these findings are generalizable. Limitations of the study was open label. There was a considerable amount of protocol violations. The study may have been underpowered due to an overly optimistic assumption of the relative risk reduction. And they adjudicated a lower number of events than anticipated, 27 compared to next slide. So the authors concluded that in pregnant women with a history of VTE, weight-adjusted intermediate dose low molecular heparin did not reduce the risk of the primary outcome of VTE compared to fixed low-dose low molecular heparin. They noted that despite the prophylaxis, the absolute risk of VTE during pregnancy up to 6 weeks postpartum was 2% and 2.9%. They did not note a difference in bleeding, major bleeding, or other types of bleeding between the 2 study arms. Next slide. If they look at the secondary outcomes, however, there was a decrease in PE, SVT, and composite VT or SVT in the intermediate dose group compared to low dose, and most of this was noted in the postpartum period. So the impact of the study is that in the antepartum stage, low-dose low molecular heparin is appropriate. The benefits of the low dose is lower costs and facilitates access to neuroaxial anesthesia. In the postpartum stage, intermediate dose appears to be more efficacious and without an increased bleeding risk. However, this was subgroup analysis, so this is only hypothesis generating, so more data is needed to confirm this finding. Okay, so next we'll move on to pharmacokinetics of DOACs after bariatric surgery, a retrospective cohort study. So the prevalence of obesity is increasing in the general population, as are bariatric surgeries. Obesity itself is a risk factor for both VTE and atrial fibrillation. So many of these patients have indications for anticoagulation. DOACs are first-line anticoagulation for both AFib and VTE. But the challenge in these patients with bariatric surgery is these surgeries can either reduce intake or cause malabsorption, which can interfere with the bioavailability of oral drugs. So with the DOAC, this can lead to lower drug levels and possible reduced effect. So here are some examples of the bariatric surgeries. We can see they differ a bit in terms of their mechanisms, if they're more restrictive or malabsorptive. Next slide. So unfortunately, there's very limited data in the use of DOACs post-bariatric surgery. So these are fairly recent guidelines from last year. They suggest in the acute setting post-bariatric surgery, so for that first 4 weeks, they suggest to use parenteral anticoagulation. After that initial 4 weeks, they suggest a switch to oral anticoagulation could be done. If switching to DOACs, they suggest to check the trough level, to check for drug absorption and bioavailability. Next slide. So at Dr. Gunka Center, this was the standard management algorithm for patients on DOACs post-bariatric surgery. They would check a peak DOAC drug level. If the drug level was low and it was deemed to be accurate, they would switch to a different DOAC. If 2 or more DOACs were low, they would consider a switch to warfarin. Next slide. So moving on to the study, the objective was to evaluate peak DOAC drug levels in patients after bariatric surgery. Next slide. They conducted a retrospective cohort study of post-bariatric patients with DOAC levels from 2015 to 2021. The anti-10A DOAC levels were measured using drug-specific anti-10A assay. The dabigatran levels were measured using dilute thrombin time calibrated to dabigatran, and they collected demographic, pharmacokinetic, and outcome data by 2 investigators. Next slide. So they looked at the peak DOAC drug levels stratified by surgery type and DOAC, and they looked at the proportion of drug levels outside of the expected ranges. They also looked at clinical outcomes of VTE, arterial thrombosis, and major bleeding per ISTH definition within the 30 days post-op. So as we know, we don't have a therapeutic range of DOAC levels. Instead, we have this expected range from the pharmacokinetic studies. So that's what we have here. Okay, next slide. So looking through the thrombosis service records and bariatric registry, they had an eligible 205 patients. From that, they narrowed it down to 45 patients after exclusions, which had 72 DOAC drug levels measured. The median age was 55.3, 45% were male. The mean BMI was 51.8. The majority of DOAC levels were rivaroxaban and apixaban. The majority of the bariatric surgeries was sleeve gastrectomy, 35. It was 9 Roona and 1 duodenal switch. Next slide. Here we have the baseline characteristics in table form. We'll go to the next slide. Okay. So here are the peak DOAC drug levels. We can see if the 72 DOAC drug levels, 29% were below the expected range. We can see that number varies based on the specific surgery they had. So for sleeve gastrectomy, 25%. For Roona gastric bypass, 33%, and for duodenal switch, 100%. Next slide. The authors did a secondary analysis after moving data that might have been inaccurate. So for example, if there's missing information, incorrect timing of blood draw, or improper administration. Next slide. So here's the next analysis. So here we have the data divided by DOACs. So with apixaban, the proportion below the expected range was 10%. For the 20 milligram of rivaroxaban, it was 15.4. For the 10 milligram, it was 50. For edoxaban, 0. And for dabigatran, 100%. Next slide. And also the proportion below the expected level varies by surgery again. So sleeve gastrectomy, 14.9%. Roona gastric bypass, 33%. Duodenal switch, 100%. Next slide. So here we have the clinical decisions. Given the time constraints, we'll skip this slide. So in terms of clinical outcomes, within the 30 days, there was 1 pulmonary embolism and 1 splenic infarct. There were no arterial thrombosis and no major bleeding. So the limitations of the study, first, it was a small sample size, so it's difficult to make any strong conclusions from this. Second, they looked at the peak drug levels. The new guidelines now suggest looking at the trough drug levels, but either way, both peak and trough, these are all surrogate markers for anticoagulant exposure. Third, the levels were compared to reference ranges of the general population. So again, these are the expected levels from pharmacokinetic studies. These are not therapeutic ranges. And fourthly, as with any retrospective study, there is that risk of missing data. Next slide. So to conclude, this was the largest cohort of patients with DOAC drug levels post-bariatric surgery. All of the patients with the bigatran had below expected levels. The malabsorptive surgeries of Roona Y and duodenal switch had a higher proportion of below expected drug levels compared to sleeve gastrectomy, and the increasing use of bariatric surgery highlights the need for more robust data. I'll now pass it on to Dr. Sam Schulman.
Thank you, Dr. Abdulrehman. So I am at the thrombosis service at McMaster University in Hamilton, and I'm also involved in the activities of ISTH, such as at the time I was chair of the Guidance and Guidelines Committee, and I'm also a member of the council. And next slide. These are my disclosures. So I presented at ISTH the guidelines, the new guidelines for antithrombotic treatment in COVID-19 on behalf of the guidelines panel and the council. And this is available online still at the Journal of Thrombosis Hemostasis. It will be in print hopefully soon. Next slide. The learning objectives at the end of presentation, participants will be able to discuss the evidence-based recommendations for antithrombotic treatments in non-hospitalized patients, in non-critically ill hospitalized patients, in critically ill hospitalized patients, and in patients discharged after hospitalization for COVID-19. Next slide. So for this guideline, the guideline methodology used was not the typical grade methodology, but the American College of Cardiology Foundation, American Heart Association. And as you can see, it's rather colorful. On the right hand, you see the level of evidence, and only recommendations that were based on studies with level A or level B evidence were included. And on the left side, you see the different classes of recommendation, the strong, moderate, weak, and harm with clear red color. Next slide. So next slide. So let's start with the non-hospitalized patients, and we could not recommend giving antiplatelet therapy to non-hospitalized patients with symptomatic COVID-19. We had the outcomes, hospitalization, arterial venous thrombosis, or mortality, and this is based on one randomized controlled trial, and that was supporting this, and cohort studies going in different directions. So no clear evidence to give antiplatelet therapy. Next slide. However, if the patient is already on antiplatelet agent for a clear indication, then one should not stop that therapy. Next slide. Moving on to direct oral anticoagulants, DOACs. Same conclusion, that it's not effective to reduce risk of hospitalization, thrombosis, or mortality, based on one randomized trial that did not show any effect. but increased major bleeding, and cohort studies that went in different directions, so totally non-conclusive, and therefore we could not recommend giving DOAC. Of course, if a patient is on for recent thrombosis or atrial fibrillation or so, one would have to keep the drug. Next slide. And here is an interesting drug called sulodexide that is only approved and available in some countries, mainly in South America, Latin America, Asia, Eastern Europe, and it is a glycosaminoglycan that is taken orally. And in a randomized controlled trial performed in Mexico, they showed that it reduced risk for hospitalization and borderline reduction of need for oxygen supplementation without any increase in bleeding. So the conclusion from the panel was that one can consider in countries where it's available to reduce the risk of hospitalization to give sulodexide, and as in the study, should be given to patients at higher risk of disease progression and within 3 days of symptoms. Next slide. Now we move on to the hospitalized non-critically ill patients. And first, we looked at prophylactic dose of low molecular weight heparin versus placebo, and this is highly recommended. It is it's not, there is no randomized clinical control trial, but there are 7 cohort studies of moderate quality, moderate to good quality, that all showed reduced mortality, maybe a little bit unexpected, but did not report risk of thromboembolism. But there are other facts that we took into account, because patients with COVID-19 have about 3 times higher risk of thrombosis compared to regular medically ill patients. And we know that low molecular weight prophylaxis lowers the risk of venous thromboembolism in patients with medically ill that are hospitalized. And patients with COVID-19, if they're hospitalized, no matter what risk assessment model you use, they will score high, which means that we should give them low molecular weight heparin. And in none of those 7 cohort studies was there increased risk of bleeding, and because of that, the class of recommendation is 1. It's a strong recommendation for. Next slide. When we go to therapeutic dose low molecular weight heparin versus prophylactic dose, we have 3 randomized controlled trials that support that, with a little bit different outcomes showing benefit, but patients were of course selected for these studies, and because of that we say in select non-critical ill patients, therapeutic dose low molecular weight heparin is beneficial to reduce risk of thromboembolism and end organ failure. And this because there was no harm showed in these studies, but just benefits that are of clinical important, like reduction of thromboembolism or reduced mortality, the class of recommendation is 1. And the select patients, so next slide. So they were selected because they had low bleeding risk, so that's to keep in mind. And they had risk factors for thromboembolism or organ failure, such as high D-dimer or increasing oxygen requirements. So that's to help know how to select these patients. Next slide. And then can you go in between and give intermediate dose instead of therapeutic dose low molecular weight heparin, unfractionated heparin? There's 1 randomized controlled trial, was not very good methodologically, but did not show any benefit of the primary outcome, but there was a difference in thrombotic events, 0 versus 6. But then for cohort studies showed inconsistent results, and because of that, we concluded that there is probably no benefit. We don't recommend intermediate dose. Next slide. And this is the final for hospitalized non-critical ill. Should they have, in addition, an antiplatelet agent? Well, we said that's potentially harmful and should not be used based on 2 studies, the randomized clinical trials that showed increased bleeding and not really an effect on efficacy outcomes. Next slide. Then if the patient already has an antiplatelet agent for a clear indication, we suggest to continue the treatment, but then they should not have therapeutic low molecular weight heparin, but they should be on the prophylactic dose to avoid increased risk of bleeding. Next slide. Oh, one more for the non-critical ill. DOAC, therapeutic dose DOAC, tested in the ACTION RCT with rivaroxaban, was not any better than heparin, low molecular weight heparin, and gave increased clinically relevant non-major bleeding. So we concluded that it's not effective and we did not recommend it. Next slide. Now we move on to the critically ill, and you will see that we have no recommendation on prophylactic dose versus placebo of low molecular weight heparin or unfractionated heparin, because we could not find any study that was of reasonable quality. There were cohort studies of poor quality, so level C, so we could not include, but we're going to say anyhow that we, based on other guidelines that recommend for all medically ill patients in intensive care unit, that they should get prophylactic low molecular weight heparin or heparin. So intermediate dose studied in 2 randomized controlled trials did not show any difference compared to prophylactic dose, so we do not recommend that. Next slide. And for therapeutic dose, low molecular weight heparin, unfractionated heparin versus usual care, which is in principle the prophylactic dose for these patients. 2 RCTs and a meta-analysis of 3 RCTs, and this is Michelle Scholzberg's meta-analysis. We could not recommend it because those randomized controlled trials did not show any benefit, and except that in the large multi-platform RCT, there was a reduction of thrombotic events, but not of organ support-free days, so, and not of mortality. Now, the next slide, in the meta-analysis, so you can see there on top, the major thrombotic events were reduced. That's driven mainly by the multi-platform RCT. But major bleeding goes in the other direction, and organ support-free days, please note, they have switched the axis here, goes also against therapeutic anticoagulation. So because of that, we could not recommend a therapeutic dose over usual care. Next slide. However, if the patient has clear indication for therapeutic anticoagulation, such as acute venous thromboembolism, mechanical heart valve, atrial fibrillation, then they should have therapeutic dose. Next slide. And for critically ill patients with already on low molecular weight heparin at the prophylactic dose, should we add an antiplatelet agent? So here we have 2 studies going in different directions. Recovery RCT that did not show reduction of mortality but increased major bleeding, and REMAP-CAP RCT that showed reduction of mortality of absolute adjusted difference of 5% at discharge, and with even higher probability of 99.7% at 90 days. So Now, there were differences between those trials that might explain the difference in result. And next slide. That can help us to select, because in the REMAP cap, and if we use that to help us, so patients were selected for lower risk of bleeding, lower dose of aspirin, because in the recovery RCT, as you see above, they use 150 milligram instead of 75 or 81. And heparin, lower dose, also that differed between the trials, and in REMAP cap, they gave gastric protection to everyone. But we are very careful, and we say, so because of these two trials going in different directions, we say not well established, but might be considered to reduce mortality in select patients. Next slide. So now we move on to the patients that are discharged, and we have only one recommendation here, and that is careful suggestion to consider low dose, so prophylactic dose rivaroxaban for approximately 30 days to reduce the risk of thromboembolism in select patients, based on one RCT and one large registry. And next slide. Selection of patients for low bleeding risk and increased risk of thrombosis, such as improved score of 4 or higher, or to improve score 2 to 3 anti-dimer above upper limit of normal. But it could be other criteria also, but this is taken from the trials. Next slide. So this summarizes the recommendations, and you can see on the left side, left column, antiplatelet agents, right column, DOACs, and in the center, glycosaminoglycans, such as selodexide on top for non-hospitalized patients, and then heparins further down, and the light green is where we didn't really feel we could make a recommendation, but we lean on other guidelines that critically ill should have prophylactic dose, low molecular weight heparin or unfractionated heparin. Next slide. And I should add also that beside this, back-to-back will be a good practice statement document with 17 statements regarding areas where there is lower level of evidence and sometimes just expert opinion, such as for patients who are pregnant or pediatric patients, or for HIT or other subsets, very obese patients, patients with severe renal failure. So like a little cookbook where there is not much evidence, but where there is usually a lot of questions. Thank you.
Thank you. So I will be going next. So thank you very much for allowing me to speak with you guys today. And I'm really bringing some of the pediatric and also a little tiny bit of hemostasis to this talk, as well as there is some hemostasis at the ISTH conference as well. So my disclosures are as listed, nothing really relevant. Next slide. So learning objectives. So I've actually got a few abstracts that I will be quickly going through. So we will be talking about prophylaxis with apixaban in pediatric ALL, as well as in pediatric cardiology patients. We'll look at MIS-C in pediatric patients and the pathogenesis, as well as some of the recommendations with regards to thrombosis prophylaxis in that population. And then very briefly, we will look at the evidence for the use of tranexamic acid in bleeding disorders patients, and we will define some of the challenges in addressing women's bleeding issues in different cultures. So to start off with, the first study was presented by Sarah O'Brien, and this is a phase 3 study looking at the safety and efficacy of apixaban for thromboprophylaxis versus the standard of care in pediatric leukemia and lymphoma patients. So As you know, about 5% of pediatric ALL patients get symptomatic VTE, and even more get unsuspected VTEs or line issues from various reasons. Patients who have VTE are known to have decreased survival from ALL in the pediatric population. But this is really the first study looking at DOAC use within ALL and the lymphoma population in pediatrics. And so this is something that is fairly well established in the adult group, but in pediatrics we have good studies in apixaban or other DOACs in pediatric populations, but not so much in that cancer population. This included all new patients with a diagnosis of ALL or lymphoblastic lymphoma in this population of 1 to 18 who were getting 3 to 4 drug induction chemotherapy, which is a standard chemotherapy for this, and who also had a CVL that was functioning. The exclusions were basically if they've had passive VTEs or coagulopathy or a super high white count of more than 200, major surgery in the near past, or were CNS 2 or 3, meaning that they would need many more procedures with LPs during their induction therapy. Exclusion were also uncontrolled hypertension and liver or renal dysfunction. As we always do in pediatrics for apixaban, we have the weight-based nomogram for dosing. And one thing to highlight in the study was it was really only that first month or the first 28-day induction period that this prophylaxis was used for. Next slide. It was quite a large study when we're looking at pediatric studies. So 74 centers across 10 countries with 512 patients that were randomized. So there's 256 patients on each arm. And most of these patients, so 98%, had more than one dose and 77 completed the treatment period. The apixaban was always held the day before a lumbar puncture and resumed the day after, and it was held if the platelet count fell to less than 20, which does happen in our ALL patients. The results showed that in the apixaban arm, the risk of thrombotic events was about 12.1% versus in the standard of care arm, it was 17.6%. So thus it was a 31% risk reduction, but this was not actually powered to be statistically significant, as it was powered to show a 50% risk reduction. Most of the thrombosis that were found were actually unsuspected DVTs, so usually they were line-related ones or ones that were not clinically significant. And once again, an important piece is that really this was only for the first 28 days of treatment or the induction period. And even in the study, they note that within the 6 days after the study period, they had 4 more symptomatic DVTs and 2 CSVTs in that time period. So when we're looking at the side effects, so the risk of bleeding was infrequent and similar in both arms. Clinically relevant non-major bleeding had more events in the apixaban arm, so 4.3% in the apixaban and 1.1% in the standard of care, which is low molecular weight, or the warfarin arm. And what's interesting is that this was more common in the kids less than 10 years. The other thing that was statistically significant was in obese patients, the VTE risk, there was a statistical decrease in that with a p-value of 0.004. Overall, apixaban was found to be safe in the pediatric ALL and lymphoma population during induction chemotherapy that contained asparaginase chemotherapy. Next slide. So the next study is looking at apixaban in congenital or acquired heart disease in pediatrics and prophylaxis. And this was presented by Dr. Payne. And one of the biggest, next slide. One of the biggest things about this population is that we actually have some good evidence, again, for DOACs in other VTEs in pediatrics, but it's not actually the standard of care in pediatric cardiology patients for the prevention of thrombosis in this population. And so the standard of care is still the vitamin K agonist or the low molecular weight heparin. And so this was looking at apixaban versus the standard of care in the study. Next slide. There was stratified into 3 groups. So those that were 28 days to 2 years, 2 years to 12 years, and then 12 years to 18 years. And it was also stratified so that the randomization, there was 2 randomized to apixaban for every 1 to the standard of care arm. Once again, the apixaban was based on weight, and so the dosing was based on weight. And what's important to note is that efficacy wasn't really what this study was looking at. So it was a composite endpoint of major and non-clinically major bleeding, but not efficacy. And so secondary endpoints looked at PK and PD, safety, and then efficacy was here, as well as quality of life. The recruitment started in 2017, and then COVID happened, and they continued, and the recruitment was completed in October 2021. 33 sites were involved from 12 countries, and there were 198 patients who were screened for the study. And 97 of those on the SOC arm completed treatment, and 95% on the apixaban arm. And you can see that most of the patients had congenital heart disease of various sorts, with a majority being single ventricles. There was also some Kawasaki disease and some other acquired heart disease as well. So when we're looking at the results, the composite of the major bleeding and the clinically relevant non-major bleeding, in the apixaban arm, there was 1 participant, so 0.79%, and then 3 participants in the SOC arm. When we're looking at all bleeding overall, it was actually 37.3% in the apixaban arm, and almost the same kind of in the standard of care arm. What was interesting is that if the patients had 1 to 3 bleeds, the rates were actually similar between both arms. But if they had more than 4 bleeds, all of them were on the apixaban arm. So there was this group of frequent flyers for bleeding events in the pediatric patients who were on the apixaban in the study. And this was mostly epistaxis, bruising, or hematoma that was significant. Next slide. And this once again shows some of the adverse events, once again highlighting that epistaxis piece, and most of the other ones were either ones that made sense based on the disease, like for example, INR is going to be high in the patients who are on warfarin, or they're fairly similar between the groups. Next slide. The results also did not find any thromboembolic events or deaths that were related to thromboembolic events in either arm. And this is what they thought would happen, as the risk of that is quite low in the pediatric population, even though that is why we are doing this thromboprophylaxis. What was also quite interesting is that there was no quality of life difference found on either the PEDS-QL or the kid clot quality of life measures. And that was interesting because one would think that, especially when you're not doing daily needles, that there would be some improvement of quality of life, but that was not found. It was found that the PK modeling well predicted the steady state levels for weight-based dosing, and that the level did not predict those who would have bleeding events. In addition, the relationship between apixaban and the chromogenic factor X had good correlation. Next slide. So overall, it shows that the safety experience is consistent with the adult data, that apixaban steady state is consistent with adult levels, and that it supports that apixaban can be used as an alternative to low molecular weight heparin and VKA in the pediatric cardiology population, with a lower major bleed rate, no thromboembolism, and no new safety concerns or signals that were found. So now we're going to change gears a little bit and go to COVID and MIS-C, which is a more common finding that we can find in the pediatric population. And the first study here is looking at the pathogenesis of COVID-19 and multisystem inflammatory syndrome in children. And this was by Dr. Carnero. And we can go to the next slide again. Perfect. And so what we see in the first box there, A, is that severe acute respiratory syndrome infection affects several body organs and special respiratory, cardiovascular, GI, and nervous system, and this causes direct tissue damage. Going on to B, then you have the innate immune response, and the activation is the first step of the host immune response, initiating inflammatory pathways that provide viral clearance. However, an innate immune response out of control may result in severe COVID-19 or MIS-C. Then in 3, or C, we have that the endothelium plays an important role in the balance of the hemostasis. Therefore, endothelial damage and inflammation promote a hypercoagulable state and thrombosis. So this is similar to what we see in the adult population, but what we know is that we can actually get that MIS-C state from this and this immune response in that pediatric population. So the next slide actually just goes through the same thing in words, and that brings us to what do we do about when we have MIS-C in the pediatric population? What is the summary of the thromboprophylaxis that is recommended in these cases? Next slide. And so that brings us to the presentation by Dr. Kumar from Boston Children's on actually treating MIS-C in COVID-19 and patients. And so here we're looking at 3 main populations. So the ambulatory group, the hospitalized patients, and then post-discharge. And we'll look at 3 areas. So one is the incidence of thrombosis, risk factors for thrombosis, and antithrombotic therapy. And I have individual slides on each of those 3 populations. Next slide. So first is the ambulatory children. So here there's very little known. The incidence of thrombosis is unknown, the risk factors are largely unknown, and antithrombotic therapy is not recommended. So this is the easiest group. Next, we have the hospitalized children. So here, the incidence of thrombosis. So VTE, the risk is about 0.7 to 7.7. In MIS-C, we know that it's 1 to 19%. And then there is also this risk of arterial ischemic stroke of 0.1 to 0.8%. So none of these are super high compared to the adult population, but the incidence is still there, and it is still quite high for the pediatric population. When we're looking at risk factors for this thrombosis, there is, of course, the MIS-C diagnosis, having the D-dimer more than 5%, 5 times the upper limit of normal, having a diagnosis of cancer, a CVL for whatever reason, being an adolescent, or having high ventilatory support. When we're looking at antithrombotic therapy recommended in this population, there's kind of 3 main guidelines that we look at. So one is the ISTH one, and here the prophylactic low molecular weight heparin is, or unfractionated heparin infusion is a recommendation, and that is really with superimposed VTE risk factors or the D-dimer being high. We also have the American College of Rheumatology and the Action MIS-C recommendations. Both of those groups look at kind of a 3-pronged effect of what you could do, either low dose aspirin, therapeutic anticoagulation with either low molecular weight heparin, and then switching to vitamin K, ANC, or DOAC, or doing prophylactic anticoagulation. And so here you can see that there's still a lot of differences in what the approaches could be, and really often, and depending on if it's being managed by the rheumatologist or the hematologist, sometimes you will get a little bit of a different approach. That is similar to the next group. If you can change the slide, of post-discharge, where the incidence of thrombosis is still largely unknown in that pediatric population. The risk factors for thrombosis are also still largely unknown. And for antithrombotic therapy, again, there's still quite a bit of difference in what the recommendations are. So when we're looking at the ISTH guidelines, we're still looking at the prophylactic low molecular weight heparin, and that can be dosed every 12 or 24 hours. And then when we're looking at the Action MIS-C or the American College of Rheumatology recommendations, we're looking more at aspirin therapy and also therapeutic anticoagulation for those certain groups until you have echo and laboratory data that is improved. And so here there is also still a little bit of discrepancy, but in general, there's a lot more evidence growing in this area and a lot more discussion that's happening in this area. Next slide. So now I'm going to quickly change gears again to talking about some of the hemostasis aspects. So first of all was when to use tranexamic acid in bleeding. And so this was by Dr. McQuilton. And we'll go to the next slide. And I don't think that there was anything that was weird or wonderful, but it was nice to have a confirmation of kind of what, are there any new studies with regards to tranexamic acid for bleeding, and are the indications still the same as they have been? And really, this study showed, or this presentation showed that really there hasn't been a huge change or a significant change in this. So the dosing kind of for the various areas is listed on the slide. The changes with regards to the or the recommendations with regards to spontaneous intracerebral hemorrhage and gastrointestinal hemorrhage, and the risk or it not really being recommended in those areas has not changed. And then for the other areas with regards to postpartum hemorrhage, traumatic brain injury and traumatic hemorrhage, there's probably some benefit in those areas, and the risk of thrombosis being increased is negligible in those areas. So there wasn't anything that was really profound, but it's nice sometimes just to confirm that nothing has changed with these meta-analyses. Next slide. The last slide was, I think, just bringing a little bit of international context and also some of the context that we sometimes need when we're treating various populations who have immigrated from various areas as well. So this was a presentation from Pakistan about raising awareness of women's bleeding and health issues in culturally challenging settings. Next slide. And this really looked at what are some of the challenges that people are facing with respect to bringing awareness about women's health and women's bleeding in these various populations. And the reason I thought that this would be nice for us to think about is just looking at, we do have patients in our population that we are seeing on a regular basis who are still coming from backgrounds here in Canada or are immigrating from areas where there is still a lot of issues with talking about women's health and talking about bleeding. And so it is important that we consider some of the cultural challenges that can arise in these settings and look at some of the barriers to care. So one of the biggest things that I thought was nice from this one is some of the reasons behind the barriers to care. So the lack of medical facilities, education, ignorance, unemployment, and poverty having some effect on that. And for us to really think about how can we make sure that we're addressing some of those barriers to care and the cultural challenges, even when we are seeing some of these patients in our groups here in Canada. And so I think it was just more of an eye-opening talk just to think a little bit more about what some of the cultural challenges are and how we can make sure that even here in Canada, we're addressing some of these issues. And I think that is my last slide.
So thank you so much, Dr. Sinha, for your presentation, and to Dr. Abdulrehman and Dr. Schulman, who I'll invite also to return to the meeting by turning on their cameras. Thank you, everybody, for your attention. Just to remind you that if you have a question for any of the panelists, please type them into the chat, addressed to everyone in the chat, and then we'll be able to address them. So I'm just going to maybe moderate a couple of questions that have come up during the time that we are speaking. And I'll ask first, Dr. Schulman, there were a lot of comments or questions about COVID and anticoagulation. One of the questions that came up at least a couple of times was the issue of whether the phenotype or the thrombotic risk associated with COVID is the same now as it was, let's say, with earlier variants or early on in the pandemic. And how do you, in terms of the evidence that have been gathered and summarized, certainly those data pertain to more early strains of the virus. Do you think that that's something that people should consider in their own practice, or how would you respond to that?
So obviously a guideline has to be based on evidence, and the evidence that we have, the randomized controlled trials, were performed in the earlier stages of the study, maybe mainly Delta, because until they got started, part of the Alpha was over already. So we cannot give recommendations for the new variants, but this is a living guideline. So we are going to come out now and then with updates, focused updates, as new studies that most likely will be based on these new variants are. But people will ask, but what do I do in the meantime? Well, if people are really sick, I think that the same recommendations still apply. And we see patients who are not vaccinated mainly, they get very sick still. So I think we should follow those. And if I may just answer the other question at the same time. So one was from a former fellow of mine from Korea asking if this applies to Asian patients. So this is an international guideline, and the panel had international representatives, including from Eastern Asia. So it is meant to be representative and to apply to even to patients in Korea. If they are sick, they should get, in our opinion, the same treatment. And the final one was, if I may quickly answer, although somebody already answered, if you switch a patient from DOAC when they are admitted to the hospital, and in the good practice statement, we say consideration should be made to switch to parenteral therapeutic dose heparin in hospital because of the potential for multiple interactions of DOACs with antiviral immunosuppressant therapy, potential loss of efficacy due to lack of immunomodulatory effects that heparins might have, and other factors that heparins have.
Okay, thank you. I just wanted to try to get one question in for the other panelists. Jameel, Dr. Abdulrehman, can you comment on, there was a comment about the dosing of low molecular weight heparin for women who had weights over 100 or 120 kilograms. Was the dose of low molecular weight heparin adjusted for those people?
Thank you for the question. So yeah, so in both the low dose, in the intermediate dose, there was dose adjustments based on the weight. So in the low dose, there was a 100 kilogram cutoff. Everyone under 100 kilogram got the standard prophylaxis dose. Over 100 kilogram got the increased dose. So for example, if it was a NOx, it would be 40. If you're under 100, if you're over 100, you'd be 60. In the low dose, that was the same dose throughout pregnancy without adjusting. In the intermediate dose, if you were over 100, that was the highest threshold. You did get a higher dose, and the dose did change during pregnancy. So for example, with the enoxaparin, again, if you were 50 to 70 kilograms, you would get 80, 70 to 100, you get 100, and then greater than 100 kilograms, you get 120 milligrams.
Yes, thanks. So there was a dose adjustment for body weight. And then finally, I had a question for Dr. Sinha. Maybe this is putting you on the spot for a small part of your talk, but of course, the data about tranexamic acid and its efficacy and safety is extremely impressive. We use it in a lot of different clinical circumstances. And but the one that I come across in my daily life is gastrointestinal bleeding. And there was on the bottom row of your table showed that, there was harm associated with tranexamic use. Do you have any thoughts about that, or how should people think about using tranexamic acid for gastrointestinal bleeding?
So my bent here again is pediatrics. And so in pediatrics, even in GI bleeding, we don't get a lot of issues with thrombosis. And so I use it in GI bleeding all the time. But I think the data is coming from the adult studies. And so this is where, Deb, I think you probably have a lot more experience than I do. But I have to say, in pediatrics, I really hand it out like candy.
Yeah, and I think, for the most part, I think that's the message, is that in postpartum, we've had good data in postpartum women, in trauma patients, in cardiac surgery and orthopedic surgery. There's lots of clinical scenarios where it's really helpful. GI bleeding appears to be one where it may not be helpful. So it's not necessarily a one size fits all, everybody gets tranexamic acid approach. So I wanted to just highlight that for people who are on the call, because I think it's an important difference between some of the other things that are mentioned and for which it is used. But thank you for showing that slide. Okay, I'll just check the chat and see if there doesn't seem to be any other comments.
You're supported by that HALT-IT study with 12,000 patients randomized with GI bleed randomized, and it did not show in any advantage of tranexamic acid. It's quite an impressive study.
Exactly. So I think we're, when we think about management of bleeding, it's often one of the adjunctive therapies that people consider, and that's appropriate in many settings, but not in GI bleeding. So that's an important takeaway message. I don't see any more questions, unless one of the other panelists wanted to ask something or make a comment. Okay, maybe we'll pull up the final slides, Holly. We just wanted to thank the sponsor again, BMS Pfizer, for allowing us the opportunity to share these findings with you tonight, and for your attention this evening. There are many things that you could be doing towards the end of the summer, so thank you for joining us. We wanted to highlight our exciting conference, which is being held on October the 15th in Toronto, Untying the Knot: Thrombosis Insights and Best Practice. You will not be disappointed. And we're very happy to have the support of healthcare providers and patients in the general public. We are a charitable organization. Please consider donating to Thrombosis Canada to help support our delivery of important educational content. Even a little bit, any amount helps. There's a link there and on our website to donate. And we will adjourn. Thank you, everyone, and have a great evening, and see you at the conference.